So Angie, I had told you that when we went into the room, I wanted you to watch how I did that technique, and I was wondering if you could give me some feedback on what you thought.
Well, it was a little different from what I learned in the classroom. I learned it in the seated position, and you did it prone.
Okay.
So,
wow. Do you think this patient would have done well with that technique, the way you've learned it?
yes, I do.
Okay.
I think she would have done great with it.
Great. Well, what we'll do next time when she comes in a couple of days, if she still needs any kind of manipulation, would you be willing to do that with her, and I'll kind of learn from you?
Yeah, definitely.
I think that would be really good.
That'd be great.
Okay. Okay, Angie, so when we went into the treatment room, I told you I was going to really be focusing in on your manual muscle testing.
Uh-huh.
And obviously I was watching everything, but I wanted to give you real specific feedback, especially on looking at the muscles of the hip abductors.
Okay.
You had the patient positioned inside lying, and that's, I think, how most of us have learned a test for abduction.
Yeah.
You also can get at information about the posterior gluteus medius muscle by externally rotating the hip a little bit and applying some pressure that way.
Okay.
So maybe next time when you are in testing hip muscles, you could use that technique to just give you a little additional information about what portion of the gluteus medius is causing some of the problems.
Okay, great.
So Angie, we've been able to treat a couple of patients this week that have a very similar diagnosis, but they're quite different patients. So I want to use a strategy that I talk about. It's called compare and contrast. We're going to sit down and talk about how they're the same and how they're different. So tell me a little bit about what you think is the same.
Well, they both have similar functional capacity as far as their 6-minute walk test.
Okay.
And they both have similar posturing. Forward head, rounded shoulders, kyphotic thoracic spine.
Yeah, absolutely. And definitely both of those things are really consistent with what we would see with someone with COPD. Okay. What do you think makes them pretty strongly different? What would be a contrast that you'd see?
Well, mostly their age. One of them's a lot older and is a little more accepting of their disease, and the other one's quite a bit younger and has a little more resentment towards it.
Yeah, and I've noticed that too, so it's very perceptive that you picked up on that. Do you think that you would handle their rehab a little differently, or do you think you want to do a very similar treatment approach with both?
I think it'd be important to do a different treatment approach for each of them. Probably the older patient, I do more functional activities as far as ADLs and around the house.
Okay.
Whereas the younger patient, I'd like to do more activities that are fun, maybe related to more balance and dynamic sort of things.
Oh, that's a great idea.
With medicine balls and
that's a great
encouragement to participate in maybe the Boulder Boulder this year.
Oh, I think that's great. And one of the pitfalls that I experienced when I first got out of school is I had kind of a similar situation where I had a patient who had COPD that was older. Okay. And I was really in the mode of functional training, but I was taking it more to I think I was just doing too high level activity with them, and they weren't really getting the take home message. They weren't really seeing how the activities would relate to them in their own lifestyle, and they got really frustrated. So I think that's actually a really good plan. And I think the reverse would be true. The younger person, if all you were doing was ambulation training, they might feel like that was too low level or not exciting enough. So I think you got it right on the money.
Okay, great.